I had the pleasure of presenting the results of the COSMIC-HF trial. COSMIC-HF was a trial that evaluated the oral dosing of omecamtiv mecarbil, which is a selective cardiac myosin activator. I imagine we'll talk more about that later. That it was investigated in patients with chronic heart failure. So omecamtiv mecarbil, as I mentioned, is a novel selective cardiac myosin activator that functions by increasing the transition rate of the myosin-actin interaction from a weakly bound interaction to a strongly bound force-generating interaction. So it doesn't require more ATP, it doesn't require more oxygen, but you're actually getting more myosin heads or more hands pulling on the actin rope with the same amount of oxygen or ATP. We have been looking for agents that improve cardiac performance since 1897 when adrenaline was first extracted. And unfortunately, the currently available agents that increase cardiac performance, which are called inotropes, these agents all increase intracellular calcium, they increase intracellular cyclic AMP, they increase myocardial oxygen demand, they increase arrhythmias, and have been suggested to increase mortality. So these are obviously not beneficial aspects of the drugs. And what's interesting is I actually just had an opportunity to give another lecture here at the American Heart Association where I asked the audience, okay, how many of you know that these agents cause those deleterious effects? And everybody raised their hands. And I said, how many of you use these drugs? And then once again, everybody raised their hands rather sheepishly, because obviously we as clinicians want to help people and not be using drugs that are dangerous. So this pursuit of drugs that improve cardiac performance has been going on for decades. What has now happened is the science has advanced to a point where we can have developed these cardiac myosin activators which can function and improve cardiac performance completely independent of these cyclic AMP calcium-dependent pathways. Omecamtiv mecarbil in these studies was given as an oral formulation. Now in all the previous successful trials from omecamtiv, it has been intravenously administered. So this is our first time at trying to figure out how to give this drug orally. So there was two phases to the trial. The first phase was a dose escalation phase where we tested three formulas of omecamtiv mecarbil at two different doses and looked at the pharmacokinetics and then selected an oral formulation to advance into dose expansion phase. I won't talk much about the dose escalation phase except that we enrolled over 90 patients and we were able to successfully select a dose that we think would have good pharmacokinetics or PK. So we advanced that formula into the dose expansion phase, which enrolled 448 patients. And these patients were randomized 1:1:1 to omecamtiv mecarbil at 25 milligrams twice a day, or omecamtiv mecarbil 25 milligrams a day, twice a day initially, and then increased to 50 milligrams twice a day based upon pharmacokinetic testing at week 8. Or a placebo group. So these three groups were then treated for 20 weeks with serial pharmacokinetic testing as well as serial echocardiograms. And then obviously they were observed for adverse events and serious adverse events and other clinical findings. And those findings, which were very compelling for us, was initially it's a pharmacokinetic study. So the first thing that we found was we were able to the oral formulation worked exactly as we had wanted it to. It was able to give very stable and reliable therapeutic concentrations in the plasma, and it avoided excessive plasma concentrations. And what we had seen in prior studies is there is this syndrome of too much of the drug, which is true of all drugs, and that seemed to occur in some patients above 1,200 nanograms per ml. We designed this trial to make sure that we didn't have anything go above 1,000 as a little extra safety margin, and it turned out that the peak concentration in our study was 812. So pharmacokinetics were great in the study. Additionally to that, we had these serial echocardiograms that were evaluating function. And one of the main findings that we saw was the pharmacologic and pharmacodynamic signature of omecamtiv mecarbil, which is an increase in systolic ejection time, was statistically significant different in both groups. Associated with that increase in systolic ejection time were increases in stroke volume, increases in left ventricular ejection fraction, and left ventricular fractional shortening. So those are all increases in ventricular function. Associated with those, we saw statistically significant improvements in left ventricular end diastolic and end systolic dimensions as well as ventricular volumes. So we have decreases in systole, and that's consistent with increased contractility, but then we also had decreases in diastole, suggesting that we may be having a longer-term ventricular remodeling effect, which we've known to be very beneficial. Both those have been very beneficial in predicting long-term beneficial outcomes. Now we have improvements in cardiac function, improvements in cardiac structure or volumes, and then in addition to that we had a physiologic marker where the patient's heart rates actually decreased in the group statistically significantly again. Then associated with that as well was a statistically significant improvement in NT-proBNP, a dramatic decrease. And so we now across the board had success in every secondary variable that we were looking at. Associated with this was a finding of a very small increase in troponins at week 20 among the omecamtiv mecarbil treated patients. This was on the level of a median level of 0.006 to 0.007. And while it was small, it was consistent. And in fact, when we stopped the drug at 20 weeks and looked again at the plasma troponin levels, we saw that they returned to baseline levels. So there was some relationship between omecamtiv mecarbil dosing and this increase in troponins. We do not know yet whether it's concentration related or related to any particular characteristics. We had seen this in prior trials, and that's one of the reasons we were looking so carefully at the troponins. The thing we haven't seen before, that I'm not aware of seeing before, is usually when you see troponins go up in relation to myocardial injury, you see decreases in heart failure, in structure, decreases in function, increases in ventricular sizes, increases in natriuretic peptides, and increases in heart rate. So we have some contradictory findings here. On the one hand, we have some of the strongest predictors of improving mortality and outcomes, which are improvements in volumes, improvements in NT-proBNP. On the other hand, we have these relatively small increases in troponin. And these levels of troponin are the kinds of increases that one gets from if you're not used to endurance exercise and you go out and do endurance exercise. This is the type of increase in troponin that we're talking about. The other thing that was a little more comforting is when we looked at clinically adjudicated events. None of those troponin increases were felt to be consistent with myocardial infarction. There were no increases in differences in adverse events or serious adverse events between placebo and omecamtiv mecarbil. And there were also no differences in terms of cardiac-specific adverse events. So overall, we still remain very enthusiastic about it, and I think many of us are saying that this is some of the most compelling phase 2 data we've ever seen in terms of efficacy. And then there's this niggling issue about the troponins. The only way we believe that we're going to eventually be able to resolve this is going to be to actually try to test it in a large phase 3 study and find out whether the risk benefit is worth it and whether we have the predicted beneficial effects on outcomes. So unlike all the other therapies that we have so far or like many of the therapies that we have for heart failure, so far, and there's no reason to believe from a biological plausibility or mechanism of action that this will change, omecamtiv mecarbil has no effect on serum potassiums, has no effect on blood pressure, has no effect on renal function, all three of which are things that complicate heart failure management with most new medications. So if all the ifs that you gave become true, that if it actually does eventually be approved, it would be the kind of drug that could be added on top of imaginably almost any regimen and hopefully provide additional benefit on top of that. Certainly the transition has been wonderful to see. I've been doing this long enough to see the transition where we first started patients on ACE inhibitors. When we first started patients on ACE inhibitors, they clearly made people feel better. But you couldn't tell in the clinic that they were helping them live longer necessarily. Then we had the advent of the beta blockers, and they're actually in clinic there was a whole period where I just wasn't invited to funerals for a while. You know, it was brilliant. It really had a dramatic impact on survival. We still have a very high mortality rate, very high morbidity rate. It still rivals cancer. So yes, it's much better, and yes, we have much further to go. And this is why I'm very encouraged by the new development programs. And yes, I'm biased to omecamtiv mecarbil, but we have multiple new programs that are coming down the pike that are trying to address these other issues. The other thing is, while we've been blessed in cardiovascular medicine to have clinical trials and development programs that have addressed issues of morbidity and mortality, the focus has been, because we've been successful in saving lives, that's where we tend to focus. In some ways, I think it will also be useful and important for us in cardiovascular medicine to focus a bit on helping patients feel better as well, because these patients can live longer. I have patients who I've taken care of for 20 plus years in clinic now, but they still could feel better. And so even if we don't have agents that help people live longer, which I believe probably omecamtiv mecarbil will be, I think there's still plenty of space in this arena to help people feel better. And I think we could take a little lesson from some of our colleagues in other disciplines where they're actually focusing more on patient-reported outcomes, on health-related quality of life and other issues, and apply that to heart failure and other areas within cardiovascular medicine.